Hi, my name is Dr. Judith Nugershell. I am the medical director of the Alzheimer's Disease Research Center and an associate professor of psychiatry at Mount Sinai. And I am here to talk to you today about assessing capacity. So, disclosures, just with respect to the following presentations, there has been no relevant financial relationships and that would be considered a conflict of interest. So my objectives for you today are to understand the basic ethical principles underlying capacity assessment, to understand the concept of informed consent, and to fundamentally understand the concept of capacity versus competence. I also want to be sure that you understand the concept of surrogate decision-making and when it is instituted. So the basic ethical principles that we practice in medicine are beneficence, which is concerning promoting well-being and providing competent medical care, doing the best for people, non-maleficence, i.e. do no harm. And through the 70s, the focus was really on the first two. And as we've all know and understand, this was in the context of a very paternalistic attitude in medicine, that we as the physicians know the best, and we will strongly guide you to make what we consider the correct decision. Starting in the late 70s, early 80s, the concept of patient autonomy and the respect for the dignity and the choices of the patient came more to the forefront, and informed consent and the right to refuse treatment became very important, as well as therefore judging the capacity to sign an informed consent. So the idea of patient autonomy is that every human being of adult years and sound mind has the right to determine what shall be done with his or her own body. And that means that surgery without a patient's consent, not in an emergency, would be battery. And there have been cases where the surgeon has been liable for damages if that happened. Obviously, this is not the same in emergent care. Competency is purely a legal determination. You are competent until and unless you are adjudicated as being incompetent. There has to be a clear and convincing set of evidence that the judge considers, and it can be both a global or a specific decision. Capacity, on the other hand, is a decision that is made by a physician. It does not have to be a psychiatrist. And it's a clinical determination about medical decision-making, and it is always decision-specific. So I will talk more about that later. In order to give informed consent, there are a number of essential components. It has to be voluntary. You have to have the capacity to understand and make the treatment decision, obviously discussing that more in a bit. And you have to have been given adequate information. You have to have been told the nature and the purpose of the treatment. You have to be told the risks of the treatment. You have to be told the hoped for benefits and outcomes, the risks of refusing the treatment, and alternative options, including no treatment, and what the risks and benefits of those things are as well. And this promotes autonomy and rational decision-making in a patient who has the ability to understand it, and it allows patients a legal course of action if they haven't really been informed. Now, if the patient has been deemed incompetent in court, then a surrogate decision maker has been appointed, and that person makes the decision. If it's an emergency, the decision can be made you know, if I don't stop this carotid from pumping out, then the patient's going to die. I can't wait for the hospital administrator to make that decision. Or in the context of very, very low risk things, there can be a waiver. So for example, in a research setting, if there's a questionnaire that doesn't collect any personally identifiable information and is completely anonymous, that can be given out as long as the IRB says it's okay. That can be have the need for informed consent waived. In addition, there are lots of things that happen in medicine all the time that do not require full informed consent. For example, if you ask somebody, you tell somebody you need to draw blood and they put their arm out, they are assenting to the procedure. And you don't actually have to go through the full risks of, well, you may end up with a bruise in the context of performing that procedure. So just a couple of points. I mean, I mentioned the first two before. You do have capacity unless you're deemed not to. But the last two are important. Having a psychiatric illness, even being committed to a psych ward, does not mean you do not have capacity. And having unconventional ideas does not mean incapacity. And I'll talk more about that. Other important pieces are that capacity assessments are time specific. I have no idea whether the patient had the capacity to make this decision a month ago or a month from now. I can just tell you about today. And I can only tell you about the specific situation, the specific medical decision. So just as a shout out from all psychiatrists everywhere, asking for a capacity consult to determine the patient's capacity to make medical decisions broadly is not a good consult. It needs to be about a specific decision. And of course, just to note that most capacity consults are prompted by the refusal of a patient to accept the doctor's recommendations. But it is important to think about whether the person has capacity as you're moving forward and making decisions in their care. So in order to make the capacity assessment, there basically need to be 4 decision-making abilities that you look at: understanding, expressing a choice, appreciation, and reasoning. So understanding is, has the necessary information for informed consent been provided to allow for a factual understanding of the illness, the treatment options, the risks, and the benefits? And this requires attention and short-term memory on the part of the patient. So when you describe the procedure to somebody, you know, you're going to need to have your toes removed because they're gangrenous. Once you've explained the procedure, you need to ask the patient to describe it back to you. Tell me what you understood about what I said, because that gives you a sense of what they understood about the procedure. They have to be able to communicate a choice. So and that choice has to be stable long enough for it to be implemented. So if you walk into somebody's room and ask about having a procedure of some kind, and then 10 minutes later, they are confused and refusing it, that probably implies that they have a delirium and probably implies that their capacity to make that decision is not there. Not definitely, but it would definitely, that kind of behavior should necessitate a further assessment. Doesn't require speech though, because, you know, person's just had a trach. They can tell you, I want this surgery, or I don't want it, or I want this procedure. As long as they're clearly able to communicate. Now we're getting into the things that are a little bit more complicated. So appreciation. So they have to believe that the information applies to them at the current time. And they have to believe that the situation will impact their future. So they can't be in complete denial. You know, I'm just having an image of a woman I talked to many years ago who they were asking me about her capacity to choose to go home with no help. And she told me she could walk and cook and do all these things. And I tried to get her out of the bed to walk across the room, and she was completely unable to do it. So she was clearly in complete denial of her current medical situation. And then you have to take that, the information, and you have to be able to manipulate it. So this is probably the highest level of cognitive function. So are the patient's conclusions logically consistent with their premise? So if somebody is a Jehovah's Witness and they have been refusing blood all of their lives, and they're telling you, I will do this procedure, but you cannot give me blood during the procedure, that conclusion, I mean, you may disagree with it, but that conclusion is logically consistent with their starting premise and is consistent with their belief system. And so that is something that you would have to respect. However, if they came to a decision via psychotic thinking, then that would not imply capacity. So if, you believe that your pancreatic cancer was inserted by the CIA and only calling J. Edgar Hoover can make them remove it. And so doing the surgery is pointless. That person does not have capacity, because they're not able to, even if they're able to understand that they have this malignancy, they don't really understand either the cause or the intervention and why it would be important. And clearly the cause is, the understanding of the cause is based on a psychotic belief. So I hope I've made this clear by now that capacity is not an all or nothing thing. It is a sliding scale. You don't need the same level of capacity for all decisions. Your capacity needed to have a mole removed is significantly different than for neurosurgery. And it really depends on the risks and benefits of the procedure. So if there's a huge risk and a low benefit, that requires an even higher standard than if there's a huge risk and a very, very high benefit. So this is, this all has to be taken into context as you're talking to the patient, as you're discussing the procedure. So the components of the capacity assessment, the most important component is the patient interview. So the patient has to have had adequate information given to them about the procedure. And in fact, if you're asking a psychiatrist to assist in this process, they also have to have adequate information about the procedure. Unless I personally have performed an ERCP recently, I'm not that well versed in exactly what the risks and benefits and recovery time and medications, et cetera, are. So, you're really going to have to engage in a partnership with somebody who you're asking to help you with a capacity assessment. And you really do have to have gone through the process of talking and giving the patient the information first. So this interview provides data that then gets integrated into the clinical scenario. There are validated tools, though, by the way, basically structured interviews that have good inter-rater reliability and really help clinicians develop the skills in assessment. And the tools, some of them are available for purchase, but they're also, if you read the articles by MacArthur, for example, they are, it really structures, it explains clearly the structure of what we're talking about here. So basically what they do is they create a structured set of questions to guide an interview to assess the capacity to make a treatment decision. And it takes somewhere around 15 or 20 minutes to administer, and it does come up with quantitative scores in the 4 decision-making abilities. But without, being that specific, these are the guidelines that you, as a clinician, use for assessing capacity. First of all, as I've said 46 times, and I will keep saying, it has to be specific to what you're assessing. And you have to make sure the patient has been informed. And then it's your job is to ask specific questions. What is your condition? What is the treatment? How is the treatment going to affect your condition? What choices do you have? What are the risks of accepting the choices, of rejecting the choices? And that would be true for not only the choice that you're discussing, but also potentially for alternatives. And what are the risks of refusing? And then having them go through their reasoning. Why are you making this decision? What does it mean? And throwing in some hypotheticals so that it's really clear that they understand what they're getting themselves into. You also want to keep an eye out for anything that might lead to a lack of capacity. For example, if you notice that the patient is hopeless, helpless, worthless, tearful, and profoundly depressed appearing, then thinking, I wonder whether this person should be evaluated for a major depression, and we should include in our discussion whether their depression is impacting their decision to have this procedure. So for example, with that mole, if it is a bad looking malignant mole, but the person says, I'm going to die anyway, there's no hope, there's no point, just leave me alone. Clearly their depression and hopelessness is impacting their ability to choose a very small local procedure. And that would require, a real questioning of whether they had capacity to make that decision. You might want to do a mini mental or a MOCA to see whether they're significantly cognitively impaired. As I mentioned with the depression, think of other psychopathology that could impair rational decision-making. Are they psychotic? Are there, the CIA or aliens involved? Consider cultural and personality issues, religious issues. And this may not be a single assessment, particularly if you're worried that the person is delirious. And you want to do, if assuming that this is not an urgent thing, oftentimes it is, but if it isn't, interventions can be instituted to try to restore capacity, fix the electrolyte balance, or, the antibiotics for the infection, and see if the person can then be approached again to have a more rational and in-depth conversation about this decision. And of course, I'm saying this in the context of a huge variety of decisions. So some are, significant decisions that will have long-term consequences, but do not need to be made immediately. And other things are absolutely urgent and need to get taken care of, in the next day. So obviously your approach to those would be different. The etiology of the lack of capacity is mostly delirium and dementia. And in fact, I read somewhere that in a hospital setting, often 25% of psychiatric consults are about capacity. Other things that can be that can impair capacity are having a poor relationship with the doctor. If I just don't trust my doctor to do anything right, that would be a problem. Or having a primary psych disorder, as we discussed. So what do you do if somebody does lack capacity? Well, if you're lucky, they'll have a living will and a healthcare proxy assigned. And of course, the healthcare proxy steps in only when the person doesn't have capacity to make that decision. In each state, there's an algorithm of next of kin as to who can make these decisions. And if there isn't somebody who's been designated a healthcare proxy, then you go through that algorithm to find somebody who can make that decision. If there's nobody available in that decision tree, or the decision is too emergent, hospital administrators can be used for surrogate decisions. And then if there's time, and if the legal system needs to get involved, then having an adjudication of incompetence, which then means that the court identifies a statutory surrogate who is a guardian who then can make these decisions. And just to be clear, this whole system allows for the patient to object if they don't agree with the assessment of incapacity or the appointment of the surrogate, and they can go to court and complain. The one caveat about not needing a psychiatrist is that if the patient is psychiatrically impaired or has mental retardation, that's not the right term. Well, whatever. That requires a specialist to do the evaluation. Otherwise, anybody. If there's no healthcare proxy or surrogate, legal surrogate, if they lack capacity and they aren't refusing treatment, then the doctor can make the decisions about routine care. And if there's a major medical procedure, then there are ways of having two licensed physicians deem what's appropriate. There are all sorts of different, each state has different requirements. And if the person lacks capacity and is adamantly refusing, then what may be required is to go to court to get a treatment over objection or a guardian appointed. This is true about nutrition and life-sustaining measures. So a legal surrogate decision maker, not your healthcare proxy, but somebody who has been appointed as your surrogate decision maker can do that. But much more simply is when the person fills in a healthcare proxy to talk to them about end-of-life issues, nutrition and life-sustaining measures. And that by clarifying their wishes, that can allow their healthcare proxy to help make those decisions. And again, there are other sub areas like withdrawing, needing, if treatment would be extraordinarily burdensome, they would likely die really soon. They would be permanently unconscious. They have something irreversible or incurable. Providing treatment would be inhumane. That can also trigger like an ethics evaluation in terms of withholding treatment. Speaking of the ethics committee, if we have two surrogates who are disagreeing, if parents are disagreeing, if the doctor really objects to the surrogate's decision about withdrawing treatment, or if somebody else in the clinical staff really disagrees with the attending about their care. And the ethics committee, all hospitals have ethics committees, and they can be brought in to help navigate the nuances of these decisions. So we have a couple of cases, and I'll just, tell you what I think about them. I'll give you a couple seconds to think about it and then tell you what I think about them. So Mrs. K is a 57-year-old female who has a history of acute renal failure. And upon presentation, she's explained the situation and is told the need for acute hemodialysis. She initially accepts and agrees to it. But an hour later, she's refusing it, saying no, and nobody ever told her, and she demands to be released. So this would be an example of what I was talking about before, being able to have a consistent response. So the likelihood is that since she's in acute renal failure, she's probably delirious. And her decisions are based on her level of confusion. And so she probably would not have capacity to make that decision. Mr. D is a 64-year-old male with long-standing history of schizophrenia who has an infected leg that requires amputation after having failed antibiotic treatment. And Mr. D believes that aliens have caused the infection in his toe and that he has special powers to cure it if he recites specific excerpts from the Bible. He says he has healed many people this way, including people with cancer, and he's refusing his amputation. So once again, here is a sort of an obvious case of where the psychotic symptoms are impacting their ability to make a rational decision. Because the psychotic symptoms, his belief that he has special powers, is impacting his decision to do the thing that will save him. And therefore, he does not have capacity. And here's another one. Mr. L, on the other hand, is an 88-year-old male with a history of schizophrenia. He has an infected leg that requires amputation. And he admits upon examination that he hears voices chronically, and he currently hears them whispering his name. He also believes that the FBI has been following him for years. When told about his leg, he acknowledges that he has the infection and that alternatives to treatment, antibiotics, haven't worked, and that his doctors are suggesting an amputation. And he talks to you and he says, I've lived a long life. I don't want to live as an amputee. And he then describes, a friend of his who was a vet who lived as an amputee, and it was very, very difficult. And he doesn't feel at 88 that he is, that he wants to do that. And that's not how he wants to live the rest of his life. So in that case, the psychosis has nothing to do with his decision. And even though you might think that, having the amputation, having the prosthesis, would be a better choice for him, he doesn't agree with you. And he is not, well, assuming he is not cognitively impaired and his psychosis is not influencing his decision, he would have capacity. So once again, common myths. Only a psychiatrist can determine capacity. No. Capacity is all or nothing. I think we've clarified that. It depends on the decision. All patients with psychiatric disorders lack capacity. Nope. I think we've just discussed that, and that clearly, as long as your psychiatric condition isn't significantly impairing your judgment, that does not imply that you don't have capacity to make a decision. Lack of decision-making capacity is a permanent condition. Well, since a great deal of lack of capacity comes in the context of delirium, and obviously we all know that people can return to baseline after a delirium, that can't possibly be true. So if you can treat the underlying psychiatric illness, if you can treat the underlying medical cause that's causing the delirium, the person may well regain capacity. And, you know, the person who gets treated for their depression says, well, thank goodness I had that incredibly malignant mole removed from my arm, because otherwise I would be dealing with potentially metastatic cancer right now, and now I'm not. Another myth is that cognitive impairment is the same as lack of capacity. So just because you have a cognitive impairment doesn't mean that you do not have capacity for all decisions. And I think of a number of things. One thing I think of is years ago, I had a colleague who was doing a study on appointing a healthcare proxy. And we were doing it in the context, she was interviewing people in the context of geriatric psychiatry clinic, and she would ask people multiply over the course of, I don't know, a few months, if they understood what a healthcare proxy was and who would they want to make their medical decisions if they couldn't make at it. And it was remarkably consistent. You know, my daughter, Beth, is the one who I want to make the decisions. And in general, their feelings about DNR, DNI, you know, if I'm in a situation where I'm not likely to recover, I do not want to be intubated, like those kind of discussions, as long as the person obviously isn't too cognitively impaired. But if you can have that discussion, it was remarkable how consistent people's thoughts and decisions were about those kind of decisions. So depending on the decision, the person may have capacity to make it. And of course, there's no need to assess capacity unless they're disagreeing with you. Obviously, that shouldn't be. So I have 2 questions here to throw in at the end. I think it's 2. Question 1 is, what are the 4 components of the 4 abilities model of capacity assessment? So I'll give you 30 seconds to read that through. Okay. So the answer is A. The 4 abilities model includes the 4 components with the acronym CRAM. Consistently communicate a choice, understand the relevant information, including the risks and the benefits and the alternatives, appreciate how the situation applies to them, and manipulate the information in a rational manner. Question 2. What is the most common cause of incapacity in medical inpatients in general hospitals? I'll give you a hint. We just talked about this. And the answer is obviously A, delirium and dementia. Now, just to go back for a moment, having a severe personality disorder could get in the way of having the capacity to think through a decision. That would definitely be a higher level consult. Language barrier, in these days of, AT&T assisted language communication, that really should not be ever a barrier, and nobody should be considered without capacity just because they don't understand you. And obviously for doctor-patient communication and for, the patient not really, the doctor and the patient not spending enough time to really understand what the risks and benefits are of the procedure, of the intervention. And that is all I have to say.